everyone. So I'm starting the webinar. Did you turn on your cameras?
Dr. Mootoo? She's okay, great. You're muted, right? So just remember when you have to do your presentation.
So the webinar has started.
Good morning, everyone, and thank you very much for joining this webinar series, the first for the 2026. My name is Sandra Jones, and I'm an advisor for the PAHO Caribbean office. Thank you very much for taking time out of your busy schedule to join this webinar. Just as a reminder to everyone, this webinar series started in late 2025 and it is being done under the project which is funded by the Indian Development Foundation, which is for the strengthening of EMTCT plus within maternal and child health. The overall purpose of the project is to provide overall technical support to countries to either attain the EMTCT gain or to maintain their certification status. The number of countries in the Caribbean that have received certification from WHO increased tremendously over the years. And the overall aim for us at PAHO is to provide the necessary information and tools to ensure that the EMTCT gains are maintained. It is from this perspective that the webinars are scheduled. Today's topic is focusing on pre-exposure prophylaxis, or PrEP as we all commonly know it, during pregnancy. A number of countries in the Caribbean have initiated PrEP as part of the HIV combination prevention package. Based on WHO's recommendation, PrEP could complement established HIV prevention strategies for pregnant and breastfeeding women as part of a comprehensive package to reduce HIV infections among women and transmission from mothers to infant, especially in countries with high HIV prevalence. The WHO recommendation, which you will hear more about for PrEP during pregnancy, is based on studies conducted, of which one of the study focused on women with HIV, on ART. And the conclusion was that there were no adverse effects of exposure to ARVs on maternal or infant outcome. In general, most data on the use of ARVs during pregnancy and breastfeeding comes from HIV positive women receiving combination ART, primarily initiated in the second or third trimester of pregnancy. Although there are an increasing proportion of women are on ART at the time of conception. Data comparing pregnancy and infant outcomes of women on tenofovir containing combination ART virus, ART versus combination without the tenofovir showed no difference. This is just a background as to why we're doing this webinar today and to ensure that we have a full understanding as to why PrEP is being recommended highly during pregnancy. I hope you will find this webinar very informative and as an additional tool for the strengthening of the EMTCT plus strategy in your country. Before we introduce the next speaker or I turn over, I want to just advise that this webinar is being recorded. And I would like to remind everyone that your mics are muted. And at the end of the presentation, there will be a question and answer period, at which time you'll be able to open your mics. So feel free at that time to unmute your mics and make your intervention. With all that said, once again, I thank you for joining. And at this time, I will hand over to Donna Dacosia Martinez, who will introduce our speaker today. Thank you very much for your time and attention. Donna, over to you, please.
Thank you. Thank you very much, Sandra. I just give me 1 second because I sent a copy of the stuff to you and I didn't keep a copy on my on my just 1 second. Okay. Okay, there we go. Just bear with me 1 second. Okay, so once again, my apologies. So it's my pleasure this morning to welcome Dr. Mallika Mootoo, who is a pediatrician and neonatologist with more than 3 decades of clinical, academic, and public health experience in Guyana and internationally. She serves as a senior physician in the chronic disease HIV program at St. Joseph Mercy Hospital and maintains a long-standing private practice in general pediatrics and neonatology. Dr. Mootoo has been a leading contributor to pediatric and HIV care through her work with national programs, regional training initiatives, and international partnerships, including the Institute of Human Virology and the National AIDS Program. A dedicated educator, she has taught pediatrics and neonatology at multiple medical institutions and frequently presents at regional conferences on HIV, pediatric care, infectious diseases, and public health. She also contributes to national guideline development, clinical mentorship, and capacity building initiatives across the Caribbean. It is now my pleasure to introduce you to Dr. Mallika Mootoo, who would present.
Thank you very much, Donna, for that nice introduction. It's my pleasure to be here today, and thank you so much for inviting me to be a part of this lecture series. It is a lecture series that is very close to my heart, and I am really honored to be able to present today. So thank you very much to everyone also for taking the time out of your very busy schedules to be with us here today. And I do hope that I will be able to share some information that may be new to you or maybe help you with your programs as we aim to eliminate HIV among children. So the title of this presentation is called PrEP in Pregnancy, because every mother deserves the tools to protect herself and her baby. These are my objectives. Basically, it's just to explain what PrEP is about, why it matters in pregnancy, why it's important in pregnancy. We'll look a little bit, as Ms. Jones mentioned, about the safety profile of PrEP in pregnancy. We'll see how we can integrate this into our national programs. So I always start off with a few slides on epidemiology. And I'd like to start off on a very positive note, showing you these two slides here that show us the great progress that has been made over the last 24 years in reducing vertical transmission of HIV and also in reducing deaths among children with HIV. We've seen a dramatic rise in this since 2011 as many countries signed on to global plans towards the elimination. A lot of this has been due to the fact that there's been increased access to PMTCT services and there are a lot more women have been started and living with HIV have been started on and remain on antiretroviral medications. But if we look very closely at these slides, we can see that there has been a slowing down in what we have been doing. And even though our progress is fast, it's not fast enough, I think, at this point for us to be able to reach the UN AIDS targets for 2030. And so we need to rethink what we're doing. Even though we are doing a really good job, we need to rethink and maybe see how we can expand our services or how we can help to make our services even better. For the year 2024, up to the end of 2024, these would be statistics that came out last year, 2025. There were an estimated 40.8 million people living with HIV. New infections were 1.3 million. But what I'm going to focus on here is the new infections among the age group less than 15 years of age. The new infections were 120,000, but I do have to say that in 2022, there were 130,000 new infections, and 2023 and 2024, the numbers have not dropped. There have been 120,000 in both years. If we break down this 120,000 new infections for the year, we could see that every day in 2024, approximately 712 children became infected with HIV. And unfortunately, approximately 250 children died from AIDS-related causes. A lot of this may have been due to inadequate access to medications, but much of it may have been because of inadequate prevention or even access to prevention. If we break down all of the statistics to a day-by-day basis, we can see that there were about 3,600 new HIV infections in both adults and children every day in 2024. And even though 50% of those were in sub-Saharan Africa, 300 were among children under the age of 15. And what we can see here is that about 50% of the new infections were among women, and among 50% were among young people. So adolescent girls and young women continue to be disproportionately affected by HIV. Over 210,000 adolescent girls and young women acquired HIV last year. Sorry, not last year, by the end of 2024, which is an average of 570 new infections every day, which is a lot. There have been a lot of gains in recent years to ensure that women who are not already on lifelong antiretroviral treatment before their pregnancies, that they're initiated in a timely manner and that they remain on treatment on a timely manner. But if we also look, we can see that there's about a third of the cases of pregnant women in 2023 and 2024 were actually women who were newly initiated on treatment in their current pregnancy. Being newly initiated while you're pregnant is a problem for your baby, because when you have a new infection with HIV, as we all know, that comes with a very high initial viral load. And as we all know, high viral loads is one major contributing factor to transmission to the baby. So what we are hoping and looking to avoid all the time is new infections in pregnancy and in breastfeeding. And this slide here shows us about new infections in children. So the majority of new pediatric HIV infections, they're not receiving ART, dropping off ART, or becoming infected during pregnancy and breastfeeding. If you look at this slide, the area in yellow is the area shows us how many women were newly infected during pregnancy and how many women were newly infected during breastfeeding. I would ask you to pay close attention to this one about breastfeeding, because this is a very large amount of women to be newly infected in breastfeeding. And I feel for many of us, this is an area that we do not capture. We do not, in many of our countries, routinely do postnatal testing. So as we can see here, incident HIV infection during pregnancy and breastfeeding does occur, and it does contribute to a significant proportion of infants who have HIV. Therefore, this is a real public health problem and is something that we do need to really consider and think about how we can change these figures. Just a few more slides. I won't be long with this. These are slides that affect us in Latin America and the Caribbean. These are our estimates from UNICEF for the year for 2025, which would be at the end of 2024. So this slide here shows us that in the Caribbean and Latin America, there were a total of 5,500 children under the age of 15 who were newly infected with HIV. This is actually approximately 5% of the total number of children worldwide who were infected by HIV. So the Caribbean and Latin America remains highly affected by HIV, and we have the highest prevalence rate outside of sub-Saharan Africa. And you can see this clearly on this slide, which shows the numbers in the other countries and regions. Our PMTCT coverage for our region. So even though we don't have a lot of pregnant women living with HIV, it seems that we do have some major challenges in preventing vertical transmission and also for women to receiving treatment during pregnancy. According to this slide, only 58% of pregnant women received ARVs while they were pregnant, which is really well below the 95% target for 2030. And there was a 17% mother-to-child transmission rate, which is again really way above even the target of 5% or less in the breastfeeding communities. So even though these figures may possibly reflect missed opportunities across the continuum of care, it may also mean that we need to expand our toolbox for EMTCT. So, well, how can we expand this toolbox? So this is where PrEP comes in. PrEP is pre-exposure prophylaxis, and I know that we are all familiar with this because many of us have, as Ms. Jones said, have used this and have integrated this into our healthcare systems in our countries. But I just have a couple of slides that just do some basics, if you'll bear with me. So what is PrEP? So PrEP is using antiretroviral medications if you're HIV negative to prevent you from getting HIV. If it is used correctly, it reduces HIV acquisition rate by over 90%. And it has been proven that when it is used consistently during pregnancy and breastfeeding, there are similar outcomes. You have to be to weigh at least 35 kilograms before you can be eligible to be on PrEP. And at the moment, there are 4 medications that have been approved for use as PrEP. 2 are oral medications and 2 are injectable medications. And the cabotegravir and the lenacapavir are the 2 injectables, and the oral PrEP as the emtricitabine and tenofovir disproxil combination, and the emtricitabine and tenofovir alafenamide combination. So just a quick overview of the PrEP side effects and safety. The startup syndrome that we're all familiar with the oral medications, there's no report of that with the injectable medications. There has been concern about kidney safety, especially with the oral medications, but there really is a small decrease in creatinine clearance, which resolves after stopping the drug. And with the Descovy or the tenofovir alafenamide combination, there's even less of a kidney-related side effect. There are no such reported side effects with either of the injectable medications. Bone safety is not an issue with the injectable medications, and is a small issue with the oral PrEP, with the tenofovir disproxil combination. It is a small decrease in bone mineral density, but doesn't cause fractures. What is probably the one thing that one side effect that the injectables have is, of course, the localized pain and tenderness at the injection site, maybe a little bit of swelling. With both injectables, with the lenacapavir, there have been reports of lumps or nodules and bruising and maybe even hardening of the skin at the injection site. For weight and lipids, it's only the Descovy that does cause a slight increase in lipids and does cause some amount of weight gain. But in general, all 4 types of PrEP are generally well tolerated, and the side effects are usually either mild or moderate, and they're usually manageable, and they do stop once you stop the PrEP. As mentioned before, we do have to look at the PrEP safety and efficacy in pregnancy. And there were a number of studies that have been conducted, and I'm pretty sure that most of you are familiar with all of them. But what has been interesting is that most of the studies have never included women who are pregnant or breastfeeding. All of the studies, many of the studies that included women, they were either given oral contraceptives to avoid them becoming pregnant, or if they did become pregnant, they were excused from the study. So we never had a whole lot of really good data on PrEP in pregnancy and during breastfeeding. So the partner study, which is one of the first studies that we had about with PrEP, which was a study that was conducted in 2008, between 2008 and 2013, and it was conducted in Kenya and Uganda. It was conducted on serodiscordant heterosexual couples, and even though it wasn't for pregnant women, there were 431 pregnancies that occurred during this time. Though the women were asked to stop the study at that point, at the ones that had been on medication at that time, they showed no statistically significant differences in pregnancy loss, preterm birth, or birth defects between the people who were actually receiving oral PrEP and those who were receiving placebo. Out of that partner study came a partners demonstration project where 30 women who were on the oral PrEP arm and who were pregnant chose to continue on oral PrEP throughout their pregnancy. This was a much smaller study, but it did give us a lot more insight as to how effective it was in preventing HIV and what was the safety of these medications. What it did show again, that there were no adverse outcomes. There was no statistically significant differences in loss of pregnancy, preterm, or birth defects between the people who took PrEP and people who did not take PrEP. There was another study called the TDF2 study, which was in Botswana between 2007 and 2010. Again, this study had heterosexual men and women. The women were asked to, who were on PrEP, were asked to use oral contraceptives to prevent them from becoming pregnant, but some of them did, of course, and some of them chose to remain on PrEP. And again, there were no adverse outcomes with this study either. The stillbirths, premature births, they were all similar to people who were not taking oral PrEP. And for the babies who were studied, who were followed up and studied later on, there was no difference at all in their growth and development, meaning in their weight, their height, their head circumference, their bone mineral densities. So none of the children who had in utero PrEP exposure had any significant development delay or were stunted in any way. For cabotegravir, the long-acting injectable PrEP, there was a study, the HPTN 84 study, which enrolled women in 7 African countries, and they compared cabotegravir with tenofovir and with the oral PrEP, the TDF FTC oral PrEP. There were 433 pregnancies that occurred during this study. 2/3 of them occurred on the cabotegravir arm. So the women were divided up, and some were given oral PrEP and some were given injectable PrEP. There were no difference in adverse outcomes between the 2 arms. I do have to mention there were 2 congenital anomalies in the cabotegravir arm, but this again statistically did not differ with the national averages in that country. There was another study that was done in Botswana, and I know I'm going to pronounce this wrong, the Shreletso Botswana study, which actually gave cabotegravir to women who were breastfeeding postpartum. And it proved to be safe postpartum and in breastfeeding. As of this, results coming out in mid last year, July 2025, it proved to be effective for HIV prevention with breastfeeding mothers, and the concentrations of the cabotegravir in the breast milk were extremely low, so that therefore infant exposure through breastfeeding was very low, and it was below 10% of the adult oral dose. The last study that I want to mention is the PURPOSE study, and this study was actually really a groundbreaking study because it actually included pregnant and breastfeeding women. It was a study where they were actually going to study the effect of lenacapavir on pregnancy, in pregnancy and in breastfeeding. So it was the first study of its kind. So interestingly enough, women are so disproportionately affected by HIV, and yet this was the first study that was done that included pregnant and breastfeeding mothers. So this study has shown us so far that it has an extremely high efficacy. There were no HIV infections among the participants who were pregnant or who were breastfeeding while they were receiving the lenacapavir. And the lenacapavir is a 6-monthly injectable, so it's just done twice a year. Pregnancy outcomes were similar to those who were in the control group, who were taking daily oral PrEP, and consistent with general population rates. Birth defects, the rate of major birth defects did not exceed background prevalence rates. In the study, there was 1 minor congenital anomaly that was reported in the lenacapavir arm, and that was actually 1 child had polydactyl. So for the infants, lenacapavir was detected at very low levels in the breastfed infants with no observed adverse effects on them. So I hope that from these studies that I've mentioned, and from the outcomes of these studies, you can see that they have checked, and they have done all the checks and balances to make sure that oral and injectable PrEP is safe in pregnancy and safe in breastfeeding. I believe at the last International AIDS Conference, that is when both lenacapavir and cabotegravir were formally declared to be safe in breastfeeding and in pregnancy. So why does PrEP matter for EMTCT? So offering PrEP in antenatal care and postnatal care is a high impact evidence-based strategy that is going to be essential for us to achieve elimination of mother-to-child transmission. So in pregnancy, we know that women have a heightened vulnerability for HIV. They are disproportionately affected and vulnerable to HIV. There are many incident infections that occur. We saw that on the slides that showed us what percentage of pediatric HIV infections are caused by women being infected in pregnancy and breastfeeding. There are some biological factors that may increase the susceptibility of women to contract HIV during pregnancy and breastfeeding, but there may also be social and behavioral factors that may increase exposure to HIV. As I said before, acute maternal infection in pregnancy and in breastfeeding equals high viral load, which elevates the risk of transmission. Using PrEP in our antenatal and postnatal clinics will work together with our other prevention strategies. And all it will do is strengthen our efforts and close the gap in our elimination efforts. So again, PrEP should complement established HIV prevention strategies for pregnant and breastfeeding women. And it should be part of a comprehensive package that we offer to women to reduce HIV infections among them and to prevent transmission. Existing safety data support the use of PrEP in pregnant and breastfeeding women who are at continuing substantial risk of HIV infection. So I have a quick question here. So which of the following statements is false about long-acting cabotegravir? It has no reported startup syndrome. It has no reported bone safety issues. It causes weight gain, especially in females, and it is safe to use in pregnancy and breastfeeding. Sandra, I'm not sure how we're going to answer this question, but maybe I can just say that the one statement that is false is the one about the weight gain. Neither the lenacapavir nor the long-acting cabotegravir cause weight gain among females. So that's something that you can tell the patients. I have a little case that I wanted to share with you. I feel that it is very relevant to this presentation. This is a case of a mother and child. So DJ is a 28-year-old mother. She is actually a primary school teacher. She became pregnant. This was her second pregnancy. It was an uneventful pregnancy. She attended antenatal care. She had 2 negative HIV tests during her pregnancy, and she had 3 non-reactive RPR results during her pregnancy. She delivered a term neonate. It was a spontaneous vaginal delivery. There were no complications. She brought her baby for her 6-week postnatal check. There were no complaints. She had no concerns. This was her second baby. She basically felt very confident. The baby had a normal physical exam. So did the mother. The mother had no complaints. Breastfeeding was encouraged, as it is in our non-PMTCT clinics. Here in Guyana, we encourage 6-month exclusive breastfeeding, and that was encouraged. A little bit of her social history. She lives alone with her infant. Her older child, because of schooling, lives with her grandparents. Her partner works in the mining sector in Guyana, so he doesn't come home very often. He comes home every 4 to 6 months. She doesn't have any other partner. She doesn't smoke. She doesn't use alcohol. And when her partner comes home, she doesn't use condoms with him. She is a very good mother. She attended a clinic for her baby every month. Baby was vaccinated, was regularly checked at clinic, was developing well. She did exclusive breastfeeding for 6 months. And then after 6 months, she introduced cereals, solids, and she continued to breastfeed until the baby was 22 months. When the baby went to the clinic for its 18-month checkup, it was noted that the baby was not gaining much weight and was called back at 20 months for a weight check. And again, the toddler wasn't gaining any weight. Baby had a distinct loss of appetite after 21 months, and there was visible weight loss by 27 months. When I saw this baby at 29 months, the baby weighed 6.7 kilograms, could no longer stand independently, and was actually too weak to walk. So an HIV rapid test was done on the baby and on the mother, which came back positive. The baby's viral load was 1.3 million copies. We were not able to get a CD4 count on this baby. Baby was screened for TB because she had a cough, which was negative. So this is actually a sad case. And this is a case of a mother who became infected while she was breastfeeding her baby. One of the things I'd like to highlight is many times we say that we're going to put women on PrEP who are high risk. And in this particular case, she would not have really been considered high risk. Though for me, the fact that her husband only came home every 4 to 6 months should have been a red flag somewhere. And more than likely, when he came home one time, he infected her. We have not been able to get him to come in for testing, so I can't say that with certainty. So I'm saying that because many times we're looking for certain risk factors and we don't see them, so we don't consider that somebody needs to be on PrEP. I think that when it comes to a breastfeeding and a pregnant woman, we need to be really sure if we're not going to start them on PrEP. We're going to be really sure that they're at absolutely no risk, because you can never really tell who is at risk. So who is eligible for PrEP? So basically, all sexually active adults and adolescents should receive information. All HIV negative pregnant women should receive information on PrEP at every antenatal visit. Once you're HIV negative and you have no signs of acute HIV infection, you're eligible for PrEP. If you are in a discordant relationship, so one partner is positive and one is negative, you are eligible for PrEP, especially if your partner is not on treatment, if your partner is not virally suppressed, or if your partner says that they're on treatment, but you don't know their viral load, excuse me. And if the negative partner requests PrEP, then yes, definitely, you should offer it to them. Anyone who's had an STI within the last 6 months should be offered PrEP. Anyone who's had to take PEP, post-exposure prophylaxis, should also be offered PrEP at the end of that post-exposure prophylaxis. Someone who has multiple sexual partners should be offered PrEP, and inconsistent condom use with multiple partners. That person should also be offered PrEP. Who can prescribe PrEP? So PrEP can be prescribed in primary health care, whereas which I believe in many of our countries that's already happening. It can be provided at STI clinics, at HIV clinics. Midwives at antenatal clinics should be trained to provide PrEP, and RNs at antenatal clinics after the initial visit with the doctors, they should be able to prescribe PrEP. This is important because one of the reasons that there is a slow uptake in some countries with PrEP is because the stigma associated with going to STI clinics or HIV clinics. So it is important that we offer PrEP at several different services. And when can you start PrEP? So you can start PrEP on the same day if the client is ready, if you're sure that the client is HIV negative, and if there are no signs of acute HIV infection. Always make sure that the client has not had a condom-less sexual exposure within the last 72 hours. If that happens, then the person may be more eligible to have NPEP and then go on to PrEP. Once you can do labs on the person and have a confirmed means of contact, The labs that you would need to do are, you would need to do an STI screen, of course, and we do recommend that you do, if you're doing oral prep, that you do a creatinine on the clients as well. You may not be able to start prep on the same day if the person had, as I said before, a very recent HIV condomless, a very recent exposure with someone who's HIV positive, or if they have condomless sex with someone whose status is unknown. If the patient has a history of renal disease, you will need to wait for the creatinine clearance if you're going to use oral prep for them. And the person has to be able to understand the requirements for prep. So about adherence to the medication, follow-up visits, lab tests. And if you're not able to contact the person when results come back, then you may need to wait until they can come back to get the results to start prep. But if possible, we always recommend that you start prep on the same day. One of the things that is you need to tell patients who are on oral prep is that they need to, for 7 days, they need to still use another form of protection, like a condom, until they get full protection. After 7 days, they can have condomless sex. At the initial visit, of course, an HIV test needs to be done. You assess for potential exposure within 72 hours, assess for HIV, acute HIV infection, counsel them about adherence. If they're using the oral prep, counsel them about the startup syndrome, explain to them why we're doing all of these labs. It's an opportunity to also screen for all of the STIs. It's an opportunity to update vaccines, Hep B and HPV vaccines. And of course, a pregnancy test should be done on anyone who isn't pregnant and starting PrEP. And of course, kidney functions. Anyone who comes and asks for PrEP, I always feel should be prioritized. Not everyone wants to disclose all of their exposures and what has happened to them in the past. But if someone is asking for PrEP, I think we should prioritize giving that person PrEP. And if you have a tool in your clinic which looks at the risk that the person is a risk-based assessment tool that helps you determine whether a person should be on PrEP or not, please don't use it to exclude an individual from PrEP service or discourage them from using PrEP. It can be a guide to the conversation on PrEP, but it shouldn't be used to exclude someone if they are requesting PrEP. So this is another question. So for which of these patients is PrEP inappropriate? A man who has sex with men who reports inconsistent condom use, a heterosexual woman in a long-term monogamous marriage who asks for PrEP, a heterosexual man with multiple sex partners of unknown HIV status, and a female partner with an acute STI. So I think number 5, none of the above would be correct, because each one of these people can have PrEP. The heterosexual woman in a long-term monogamous marriage is actually asking for PrEP, so she must know why she's asking for it. So she may not fit in to the risk-based assessment, but she is asking for it, so she should be given information and started on PrEP. Once you start a patient on PrEP, it's like any other medication that we start our patients on. There has to be ongoing assessments. For the oral PrEP, it's a little bit more often than for the injectable PrEP. So for at least every 3 months, the patient should come in and do an HIV test and should be assessed for signs of acute HIV infection. Prescription refills can be given. You need to answer any questions that they have, talk to them about whether they still need to be on PrEP, whether they still want to be on PrEP, and of course use every 3 months or every 6 months to monitor them for STIs. If the patient had a compromised creatinine clearance or compromised GFR when they started oral PrEP, then every 6 months they should be monitored. Their creatinine should be monitored. If they had a normal one, then every 12 months is enough for it to be monitored. For patients using the TAF, then you should also every 12 months monitor their lipid profile as well. And screening for STI should happen every year. For patients using the injectable medications, it's a little bit different with the injectable cabotegravir. When you start cabotegravir, you do 2 months of monthly injection. So the first 2 months, they get an injection every month. And then afterwards, it's every 2 months. So their first visit, the visit after the first month, the first initial injection, again, you would do the same thing. You test for HIV, you assess them for acute infection, give them any, answer any questions that the patients have, and give them any advice you can about adherence, about coming in on time, set up appointment reminders for them if they need to come in and get their need reminders on when to come in and get their injections. Every visit, they need to be tested for HIV and assessed. And then, of course, every 6 months, they should be screened for bacterial STIs, and every 12 months for chlamydia, even if they're asymptomatic. With the newer drug, it's a little bit different because this is the lenacapavir, because this is a 6-monthly medication. So visits are every 6 months plus or minus 2 weeks. It would be advisable that they do their HIV test before coming in, like maybe the day before or just before their appointment, so that you have that result before you administer their next 6-monthly injection. Of course, every visit, you test them for HIV, you confirm that they're negative before you give them the injection, assess them for any signs or symptoms of any acute infections, screen them for STIs, assess their injection sites. This is the injectable that can sometimes cause pain and hardening nodules under the skin. So you do assess their injection sites for this. Lenacapavir is given subcutaneously. You also discussed with them the benefits of remaining on the medication if this is a pregnant woman during her if this is a pregnant woman during her breastfeeding stages as well. Impress on her the importance of continuing it throughout the time that she's going to be breastfeeding. So if PrEP is so good, what is the reason that we haven't all embraced it? So we do need to integrate it into our maternal health care, into our antenatal clinics and postnatal clinics. We know that our region has one of the highest prevalence rates outside of sub-Saharan Africa. We know that women in our countries are disproportionately affected by HIV. So introducing PrEP as part of our elimination program aligns with the international efforts to reduce pediatric HIV and to improve maternal health outcomes. If incorporating long-acting PrEP ensures protection to these mothers during their highest risk stages during pregnancy and breastfeeding, and it will also help us to address gaps in the traditional prevention methods that we are already using. We know that we have really good methods, and we know that we've been doing a really good job so far, but we do need to tighten that gap and narrow it down a little bit more. So community outreach is important with these EMTCT programs where we're going to use PrEP. There are a lot of misconceptions out there about using PrEP and why a woman should or should not use PrEP. So I think engaging the local community, doing awareness campaigns will help to promote maybe acceptance and encourage women to use PrEP and maybe reduce the stigma of using PrEP. we have seen from the studies that have been done that it has been established that PrEP effectively reduces the risk of transmission, HIV transmission in pregnant women and in breastfeeding women. We need to make sure that women know how to use it correctly, and we just need to make sure that they keep their appointments, they adhere to their appointments, and they use it in the way that it will give them maximum protection during pregnancy and breastfeeding. So what are some of the barriers to us implementing this? I think limited awareness is on both sides, on the sides of healthcare providers and also on the side of the general public, is one of the biggest barriers to the uptake of PrEP, and it could be to the uptake of PrEP in pregnancy as well. So we probably need to do a lot more training for our healthcare providers. And when I say healthcare providers, I don't mean those of us already working in HIV care and treatment or those of us working in STI clinics. It has to be for our other colleagues who are working in family medicine, in family practices, OBGYNs, RNs, midwives. We need to extend the trainings so more people are aware of PrEP and more people are able to talk about it and to encourage people to use it. For the clients, maybe sometimes peer education sessions would be good. So if we educate people in the community, excuse me, who can then do training of train other people and talk to people in their community about PrEP. Another thing is workload burden. In many clinics, people are already overworked and overtaxed, and adding something else to their plate can, of course, be difficult. But maybe this is a chance to also task shift, to digitalize registers. So if we train RNs and we train midwives to give prescriptions for PrEP, to do the basic screening for them when they come for their follow-up visits, it could help all of us, and it could help us to be more effective in reaching more people. I mentioned the access challenges. So one of the challenges that I know that we have had here in Guyana is people are reluctant to go to an established HIV care and treatment site or to an STI clinic to get PrEP. They feel that there's a certain amount of stigma attached and that people will think that they're HIV positive if they go to those sites for PrEP. So it is good for us to have a differentiated service delivery here, to have other clinics give PrEP, to maybe have people go out into the community and offer PrEP information in the community. So you don't have to come into the clinic to get that information. It's out there in your areas, and then you can go to your local health center to get your PrEP. Or you can go to your family medicine doctor and collect your PrEP. I think that would really help a lot more people to access it. And if it was already being offered in your antenatal clinic, it isn't something that you have to specifically ask for. It's already being offered to you, then might be a better uptake. There are some adherence difficulties with the oral PrEP, especially in the beginning of pregnancy. Some women vomit not only in the beginning of their pregnancy, but throughout their pregnancy, or may feel nauseous throughout their pregnancy. So if you can teach people how to manage their symptoms, and that's where peer education comes in a lot. I recently had a session with some pregnant women, excuse me, and it was very good to see how they each shared their experiences and shared examples of how they overcame certain difficulties during their pregnancy. It's actually more effective when they hear it from each other. Another thing that I think we need to be careful with in our willingness to give PrEP to people is allow the pregnant woman to make her decision. So we need to respect her autonomy in making a decision for her health and for her baby's health. Yes, we will give her all the possible advice and we will explain to her why this is good for her and why this is good for her baby. But ultimately, the final decision is with her, and we must respect that. There are also some cultural stigmas. There are misconceptions about women seeking HIV prevention during prenatal care. There's a lot of talk and whispering as to why she wants to do that. And that's why awareness campaigns could actually be helpful. And then, of course, there's the whole partner dynamic. A lack of support from a partner may complicate a woman's ability to access or even to adhere to PrEP effectively. So partner engagement is actually important. And at every visit, if the partner is not engaged or not on board with the PrEP, please check for signs of intimate partner violence. And one of the ways that we could actually offer PrEP is to do an opt-out approach, which I'm not sure if this is already being done in some of our countries, so that you offer PrEP at every antenatal and postnatal or adolescent health clinic. So you normalize prevention. You make it seem that this is something that you should be doing. A same-day start always helps if the person doesn't have to come back in again to get the medication once they've made the decision that they want it. Counseling on adherence, on follow-up visits, mention the 7-day lead-in always, mention always that PrEP prevents HIV. It does not prevent STIs. If you are in your antenatal clinic and you're offering PrEP and starting a pregnant woman on PrEP, then try to align her visits for her PrEP refills with her antenatal visits. If you're giving it in a postnatal clinic to a breastfeeding mother, then try to align her visits for her refills when her baby comes to clinic. So she doesn't have to make an extra trip to come to clinic. It's all part of a normal routine care for her then. Support systems are important, reminders, pill boxes, reminders for them when to come to clinic, especially if they're doing the injectables. It is important that they are reminded when to come for their injection. Pill boxes may help sometimes if they're taking oral PrEP, just to remind them to take medication every day. We can do reminders via SMS, via WhatsApp. And then, of course, task shifting, have the RN or the community health nurse do the refills for the patients. Last question. Which of the following statements is true? Only oral PrEP medications are safe to give to breastfeeding mothers. PrEP can only be prescribed by an infectious disease or HIV specialist. PrEP medications are generally well tolerated and side effects are typically mild to moderate, manageable, and temporary. And PrEP can only be prescribed for MSM and TG women. So I think after all that I've said, it's obvious that number 3 is the one that is true. We know from all the studies that have been done that oral PrEP and injectable PrEP are safe to give to breastfeeding mothers. And we've just talked about task shifting and expanding the PrEP outreach and accessibility. So we want it to be not just at HIV care and treatment sites. We want it to be available all over. And it is for everyone. It is not just for MSM or transgender women. So these are just a few recommendations for PrEP in pregnancy. So maybe one of the things that we all need to think about is updating our national guidelines to include PrEP in pregnancy. In our clinical practice, we need to probably standardize all of our protocols. So standardize implementing same-day start when possible, and what are the protocols for implementing same-day start. If you're dealing with a pregnant woman, make it mandatory that she's retested in every trimester. Have a safety register, monitor the safety. So have a register that where you have the PrEP exposed mothers in a register, so you can monitor the safety outcomes of their pregnancy. This is important data to have, and this is the type of data that helps to propel projects forward. And then let us have clear guidelines about the product choices, whether we're using orals, whether we're using injectables, and how do we use them. In our health systems, obviously, we need to do capacity building. We need to do training programs. We need to educate all of our health workers on administering PrEP. We need to also educate them on how to counsel patients on PrEP, how to recognize barriers to adherence, and how to make PrEP seem normal in an antenatal care and a postnatal care setting. We may need to equip health centers and clinics with tools, computers, connectivity, fridges if they need to store the injectable medications. And we need to place a lot of focus on monitoring and evaluation, adding PrEP indicators to our EMTCT dashboard, just monitoring the impact of this initiative, then monitoring the impact of the scale up, seeing if we're having the same quality, the same outcomes when we do a scale up. We need to define what are our core indicators and track them, monitor retesting, how many people actually come to be retested, and of course, monitoring seroconversion. One of the things that I really would like to stress is we need to always have evidence-based, we need to practice evidence-based medicines, and we need to have evidence-based innovations. So we need to highlight the studies and data that tell us that PrEP is safe and it's good in preventing HIV infection. We need to do a lot more community education, and we need to be driven by data. We need to keep good data so that we can actually use this data to influence policies and to dispel any misconceptions about PrEP in maternal and child health programs. The expected outcomes for this would be that there's increased awareness about PrEP. There's an understanding that PrEP is a critical prevention tool for EMTCT. We need to have practical integration, strengthen advocacy, and we need to have regional consensus. We need to have actionable, context-ready recommendations for incorporating opt-out or any other PrEP models into existing maternal child health services. And we need to have a unified voice for evidence-based innovations, which will help us to drive this triple elimination project. And of course, we need to agree on timelines and roadmaps for a Caribbean-wide implementation. I am always faulted for not looking at the cost and the impact of cost on any new project. I have one slide on it. So the cost and the impact. So can you really put a cost on a child's life? And preventing one pediatric HIV case saves a lifetime of ART costs. I think it is well worth thinking about preventing HIV in pregnancy and breastfeeding. So I am almost done here. The key take-home messages here is that pregnancy is a high-risk period. Pregnancy and breastfeeding are high-risk periods. PrEP is safe and effective, and EMTCT needs prevention. It needs another tool in the toolbox, and I think that this would be the tool. If EMTCT targets focus on treating HIV in pregnancy, then PrEP helps to prevent HIV in pregnancy, and both are required for us to have sustainable elimination. So for clinicians, offer PrEP. For people who are program managers, let us pilot and monitor this initiative. And for the policymakers, help us to enable this scale, to enable the scale up. These are my references, and thank you so very much for your attention.
Thank you. Thank you very much, Dr. Mootoo. I would now like to invite our participants to pose any questions that they may have. I'm already seeing in the webinar chat, I am seeing two questions, but you also have the alternative of raising your hands. But Sandra, I don't know, but I'm not seeing for all the participants. But we have over 85 of 86 of them present. So I don't know how I'd see the hands. I'll probably just open the chat and see where your hand, who has their hand up so that they can ask a question directly to Dr. Mootoo. But let's start with the two that are here in the chat. This is from Mishak Hedgewall, and he's saying regarding HIV negative tests before using PrEP. We just need to accept that the patient may not have seroconverted over the typical 3-month period yet. Current HIV negative with no condomless sex in last 3 days is acceptable. And he's asking that in the form of a question. So, Dr. Mootoo, if you would kindly respond.
Yes, really good question. Thank you very much. So yes, I do know that it is possible that they haven't seroconverted, but that's one of the reasons why it is really important to assess them for an acute HIV infection. So they may have the signs and symptoms of an acute HIV infection before you can see that test being positive. And so it would be important that you assess them. If you have any doubt at all, then put them on PEP. And then after PEP, you can retest them again, and then you can go on to PrEP.
I'm not seeing any additional hand raised, Donna, so I will check for raised hands. You could see if there are additional questions in the chat.
I see a question here from someone. I can answer that question. It's from someone called Sharon. Sharon, I do understand your question. I'll just read it out for everyone. It's about the midwives and RNs prescribing PrEP. Is it that you meant recommend because nurses and midwives have limitations within their scope of practice? I do understand the limitations, and the limitations are different in every country. I do mean recommending, but in some countries, some of the RNs are allowed to do prescription refills. And if they are allowed to do that, then that would be very helpful.
Okay, Dr. Mootoo, I'm seeing another one from Ishian Prasad, which says, how soon would the injectable PrEP become available, especially for the undetectable patients or partners?
Well, I'm not a policymaker, so I'm afraid I can't answer that question. If it were up to me, it would be here yesterday. Maybe Sandra can give us more light on that.
I think a big part of the availability right now is the cost. The costs for the injectables are very expensive. I know at PAHO we were trying to see to have some kind of discussion with the companies to see how we could get the costs down. We have not reached any agreement as yet, but this is something that we're trying to do. So I think as soon as it is affordable, and I know this is something that also Global Fund is looking at to ensure availability to countries that are recipient of Global Fund to actually to see how they can also procure the medication. But I would say hopefully within a year or so it should be at the point where it is affordable for us in the region.
I am not seeing any more questions in the chat.
Just a follow-up to what Sandra said. I mean, I know that obviously the injectables would be easier to administer and we would have better adherence with it, but it still doesn't stop us from using the oral prep. We've seen that it has been safe and effective. Um, I know taking pills every day is not many people like doing it, but it is if we think that someone is possibly at risk, or if the person asks or says that they're not sure if their partner is cheating on them, then we should offer the oral prep. And maybe if we start offering the oral prep, we start keeping good data on it, it could actually help the policymakers to push for us to have the injectables.
I'm not seeing any more questions.
Yeah.
Sandra, you seeing anything in
No, I'm not seeing any
okay,
more, no raised hands, so I think we're good.
okay.
So I think
Yeah.
Dr. Mutu, your presentation was clear, concise, and to the point, and we thank you very much.
Thank you very much for having me. It was a real pleasure to be a part of this series.
Yes. Donna, we need to inform participants about the
Yes.
availability of the recording. You could go ahead.
Yes, okay. So again, thank you very much, Doc, for your remarks. It is planned in the next coming months that we would have at least one webinar per month. One of the things is that the next one that's coming up in March would be on screening and clinical management of the pregnant woman. And this, we would also be asking countries to give examples of their experiences and so on. So that's something that you can look out for.
For
We
hepatitis B.
Yes, for hepatitis B, and that's something that you all can look out for. Also, you would receive a copy of the presentation, and we will also be including there an evaluation. This is very, very important for us to see how you are benefiting from these sessions. So I would really urge you all to, when you receive it, it's going to come in the form of a Google Doc. And if you can fill that out so that then we can pull all that information together to analyze it. So again, I want to thank all of you, Dr. Mootoo, as well as the participants who asked questions. Thank you so much for your interest, and we look forward again to seeing you soon within the next month. So you can look out for more information on that.
Donna, I just saw in the chat someone was asking about the availability of CME credits. And that's a little bit challenge for us because each country has different requirements for CME credits. But we would need to see how we could discuss with if there's a point person at the country level. We at PAHO cannot organize and do the CME credits, but if there is some point person who is willing to take that on to ensure that individuals who participate from the countries receive the CME, we will explore to see what is possible. Yeah. So thank you very much on behalf of PAHO, and I would say on behalf of CARICOM, because this project is implemented with PAHO in collaboration with CARICOM. We thank you very much for joining, and we look forward to seeing you and others at the next webinar, which we will be sharing the information shortly. Donna, thank you for the support. Dr. Mutu, thank you very much for your willingness and commitment to ending AIDS in the Caribbean. Have a wonderful day, everyone. Thank you.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Donna,
Mm-hmm.
don't go yet. I'm not seeing where Sharon told me.
Okay.
Let me see.
You have to stop the recording.
No, yeah, I will do that, but
Mm-hmm.
I'm looking for